So good morning, everyone. It's my pleasure to introduce our distinguished speaker for today's Grand Round, Dr. Justin Kwan. Dr. Kwan is a clinician researcher with extensive expertise in ALS and FTD spectrum disorders, and currently serves as the director of Neurodegenerative Disorders Clinic and an associate research physician at the NINDS/NIH. Dr. Kwan is the author of over 60 peer-reviewed publications and book chapters with a focus on ALS and neuromuscular disorders. Additionally, he has played a key role as a PI and co-PI in numerous studies in this field. Dr. Kwan trained at Baylor College of Medicine, where he completed his neurology residency and neuromuscular medicine fellowship, followed by a research fellowship at the NIH in the field of motor neuron disorders. Before joining the NIH in 2020, he held faculty positions at Temple University, Baylor College of Medicine, and the University of Maryland, serving in leadership roles in ALS clinics across these institutions. He is board certified in neurology, neuromuscular medicine, clinical neuromuscular pathology, and electrodiagnostic medicine. Today, we have the privilege of hearing from Dr. Kwan as he shares his insights on ALS clinical trials. Please join me in welcoming Dr. Justin Kwan.
Well, thank you, Dr. Baya, for that very kind and generous introduction. And it is a pleasure and honor to be able to give a talk at GW, where there is long-standing established history of phenomenal care and research in neuromuscular medicine, including I just found out recently, previous chair, Dr. Kaminsky, as well as Dr. Bayat. So thank you for this for this opportunity. So for the next hour, what I like to do is talk about what we have learned in ALS clinical trial in the past 20 to 25 years. The purpose of this talk is not to discuss the aspects of the individual trial, but rather, I think that the main takeaway message is what could we learn from trial, whether it's successful or not successful in ALS. So I have no disclosures, and I will not be discussing any off-label use of any pharmaceutical products. So I'd like to start with a slide from Henry Ford, where he said, "Failure is simply the opportunity to begin again, this time more intelligently." And I think that this particular phrase cannot be more appropriate given this challenging time that we're facing in the field of ALS, where we had a very exciting 2 years where there were 2 FDA-approved products that was brought to the market. And unfortunately, last year, one of those was removed from the market because additional phase 3 clinical trial showed that it did not meet its endpoint. So I think that what Henry Ford teaches us is that we should not think of failure as the end, but in fact, a new beginning for us to do things differently and to learn from our previous limitations. So in the next hour, we will first briefly discuss what is ALS. And the second question that we will address is why all the failed trials? And the third, which is more important, is what have the ALS clinical trials, whether successful or failed, taught us as clinicians and researchers? And finally, I'd like to conclude with a couple of remarks in terms of what is the future of ALS clinical trials globally. So I think Dr. Bayat very kindly reminded us that Charcot, the famous French neurologist who coined the term la sclérose amyotrophique, birthday, it will be coming up this July. 2025 marks his 200th birthday. And I think it is appropriate that we start our introduction to ALS with a reminder that Charcot first coined this term. And he, in fact, described ALS as early as 1865. When he described a woman who he probably pathologically provided description of the sclerosis of lateral cords of spinal cord. And she also had contractures of all 4 limbs. Subsequently, 4 years later, Charcot and Joffrey further described two cases of what they called progressive muscular atrophy with lesion in the gray substance, which is quite correct anatomically, and of the anterolateral tract of the spinal cord. And I think that Charcot really taught us what very early on, what is a clinical phenomenology and pathology that is critical for us to recognize in this rare and unique and complex disease. Interestingly, Charcot said at that time that the diagnosis as well as anatomy and physiology of the condition of amyotrophic lateral sclerosis is one of the most completely understood condition in the realm of clinical neurology. That, I would say, may be true for Charcot, but I venture to disagree with him, that I would posit that, in fact, ALS is a quite complex condition. Although the name sounds fairly straightforward, amyotrophic meaning lack of muscle or no muscle, lateral sclerosis referring to the scarring of the anterolateral corticospinal tract seems very straightforward, and that it is the most common adult onset motor neuron disease. ALS is in fact quite a complex disease. While we classically describe the classic presentation of ALS as a disorder of the cortical and bulbar and spinal motor neuron, presenting as upper motor neuron dysfunction as revealed clinically on examination, ALS presentation can be quite complex. In some individuals, the symptoms may be restricted to one region of the craniospinal axis. As an example shown up here, you have some individuals whose symptoms are confined to the bulbar region or to the brainstem motor neurons, whereas others, the degeneration of motor neurons are confined to either the anterior horn or the motor cortex, presenting as progressive muscular atrophy or primary lateral sclerosis. In the past, there has been some debate in the literature whether these truly, in fact, represent forms of ALS. But more recently, with more advancements in molecular biology and our anatomical study of postmortem tissue, we have to recognize that they, in fact, have shared pathology, therefore, most likely belong under the overall rubric of ALS. There are other unusual presentations of ALS in which patients do not follow the typical pattern. As an example, some individuals may have what we call pseudo-polyneuritic pattern of ALS, in which it mimics a distal motor neuropathy. Some folks can have what we call hemiplegic ALS, where the symptom starts affecting half the body with predominantly upper motor neuron clinical findings, whereas some of the rare forms of ALS can include flail arm syndrome and flail leg syndrome, where the motor neuron degeneration remains confined relatively to the cervical and lumbar spinal cord before progressing to more diffusely. What makes ALS even more complicated, aside from the complex motor clinical presentation, is a recent recognition that ALS, in fact, belongs on a spectrum of disorders of ALS FTD. While most patients, approximately 50% of patients with ALS, will have normal cognition and behavior, another 50% may have varying degrees of cognitive and behavioral impairment, with about approximately 10 to 15% of the patient meeting the diagnostic criteria for behavioral variant FTD. Similarly, we see that while vast majority of patients with FTD, the symptoms remain are confined to cognitive symptoms, approximately 10 to 15% of patients with FTD may go on to develop motor disorder and meet the diagnostic criteria for ALS. The reason that this heterogeneity in clinical presentation makes it challenging for clinical trials is that sometimes the earliest symptoms for the patients may not meet the classic diagnostic criteria for ALS. As a result, the obscure or sometimes ambiguous early symptoms may result in delayed diagnosis and delayed enrollment in clinical trials. Further complicating ALS is the fact that numerous genes have been discovered over the past 30 years that are known to cause either ALS, FTD, or both, sometimes even within the same family. And this is an illustration of the different genetic discoveries that have been made over the past 20 to 30 years. And C9orf72 continues to be the most common genetic cause of familial ALS of people of European descent. And that's, again, I always like to emphasize that point that, in fact, C9orf72 is very rarely seen in individuals of Asian or African, pure Asian or African genetic background. So it is important to really obtain a thorough history to make sure that you understand uh, the genetic background of your patient when you think about genetic testing in these individuals. And finally, ALS is also pathologically heterogeneous. While TDP-43 continues to remain the most common pathology when we examine postmortem tissue, we know that approximately 20% of familial ALS is caused by SOD1, in which the patients may have SOD1 inclusions in the motor neurons, and even a small fraction of the individuals may in fact have FUS mutations, and they have these FUS inclusions in the motor neurons. So while our understanding of ALS has markedly advanced over the past 30 years or so, the clinical trials really has not kept pace. And this is the illustration of all the ALS clinical trials that has not met its endpoint, and which has been very disappointing for the field, and even more so for our patients and their caregivers. So why is it that, in spite of all the knowledge that has been gained about the molecular biology, genetics, and clinical phenotype of ALS-FTD, we still have not been able to come up with an effective treatment? I would say that the first limitation in terms of it comes in the form of diagnosis. As I had mentioned, ALS is a clinically heterogeneous disorder, and often the first sign of the symptom can be rather nonspecific. And as you can see here in this illustration, even in 2025, it can take up to 12 to sometimes to 14 months before a patient is able to be diagnosed with ALS and enrolled in multidisciplinary care team. And really, the window of opportunity for us to recruit these patients is approximately between 12 to 24 months, because many clinical trials are now targeting patients with earlier symptom onset, and the inclusion criteria is limited to disease symptoms before 24 months from symptom onset. Therefore, this window is quickly closing as patients' diagnostic delay becomes prolonged. So one of the first steps that we need to take as a field is to shift the needle by earlier diagnosis and really educating our general neurologist and general practitioner to bring these patients and refer those patients to a neuromuscular specialist for a more rapid diagnosis when the ALS is a diagnosis of concern. Other reasons for all the negative clinical trial includes sometimes a flawed or irrelevant preclinical models. The rationale may be incorrect. Other concerns may be the design methodology may be flawed due to disease heterogeneity or recruiting patients who have more advanced disease. And additionally, they may be overly optimistic effect size for the drug under study. Other limitations may include the pharmacology of the medication, including incorrect dosing, poor CNS penetration, and more importantly, there's no relevant biomarker to demonstrate target engagement. So as we all know, an effective clinical trial requires 4 fundamental pillars: the right target, meaning a druggable and known disease mechanism; the right drug with the right mechanism of action, appropriate PK and PD, and acceptable toxicity to the patient; the right patient, meaning that the diagnosis must be correct. We need to consider the staging and the potential risk for the patient to undergo the particular clinical trial. And finally, the right trial, where the trial must be adequately powered, the outcome measure must be clear and achievable, and the duration must be of reasonable time period so that the patient to enhance recruitment and retention. So I like to present 5 lessons that we have learned over the years from clinical trials. And again, these will not be a detailed examination of the clinical trials themselves, but to really discuss what specific lessons can we take away from some of these clinical trials, whether they're successful or unsuccessful. The first trial I would like to discuss is the Reuville trial. So for many years, it has long been hypothesized that glutamate toxicity plays a critical role in neurodegeneration and amyotrophic lateral sclerosis. And this led to the clinical trial for glutamate that was published in New England Journal of Medicine in 1994. And this is one of the pivotal trials that led to the FDA approval of Riluzole for treatment of ALS. And in this trial, it was demonstrated that in patients who were on Riluzole compared to placebo, the patient had a prolonged survival, um, uh, particularly in people who with bulbar onset disease. And what was the outcome of Riluzole was that it provided some clinical evidence that, in fact, glutamate toxicity plays an important role in neurodegeneration in ALS. And it led to the further exploration of the role of the excitotoxic amino acid transporter 2 on the astrocyte to uptake glutamate in order to decrease excitotoxicity. And the lesson that was taken away from this clinical trial was, in fact, that it led to the question of how is it that the glutamate is normally regulated in the central nervous system. And this ultimately led to a paper that was published by Jeff Rothstein and his group in Johns Hopkins, where they discovered that, in fact, it was aberrant RNA processing in the astrocytes, resulting in decreased EAAT2, resulting in excess glutamate in the synapse that caused excitotoxicity. So the lesson to be taken away from this successful clinical trial where the stars all aligned, the right drug, the right patient at the right time, led to further discoveries of the important role of EAAT2 in mediating and alleviating potentially excitotoxicity in ALS. The second study that I'd like to briefly discuss is how did BDNF clinical trial lead to a better understanding of a more robust outcome measure in ALS? So the idea that neurotrophic growth factor may be helpful as a treatment in ALS is a long-standing hypothesis. And this really led to the study of the BDNF in ALS in the late 90s, a phase 3 trial. The outcome measure was survival in this particular trial. However, during that time, the idea that survival as an outcome measure had become increasingly challenged by the field. While it is an unambiguous endpoint, which is its major strength, survival had suffered from a number of weaknesses, including the requirement for a large number of patients and the potential influence by psychological factors and the level of variability of palliative care accessible by the patient, and finally, by the increasing widely use of non-invasive ventilation, which in itself can prolong survival for patients. One of the important data points that was included in the BDNF trial was that the investigators also included all the measures required to produce an ALS-FRS, as well as a new measure called the ALS Functional Rating Scale revised. This is not so new to us today, but back then it was considered a transformative outcome measure for the field of ALS. The ALS-FRS was then revised from a 10 to 12 item scale, and factor analysis was performed on the BDNF data, which then determined there were 4 clusters: the fine motor, gross motor, and bulbar respiratory function. It was found that ALS-FRS and ALS-FRSR share some attributes, including high internal consistency, as evidenced by high Cronbach's alpha. Additionally, there was construct validity for the ALS revised functional rating scale because it correlated with individuals' function as determined in this trial, as well as it predicted survival. As a result of the BDNF study and the data obtained from this study that failed to achieve its endpoint, the ALS functional rating scale is now established as the primary outcome measure for most ALS clinical trials globally. So the third study that I'd like to briefly discuss is extension of the concept of glutamate toxicity. So as a result of the discoveries that EAT2 plays an important regulatory role in modulating glutamate transmission at the synapse for motor neurons, Jeff Rothstein and his group further explored what are potential druggable targets in this pathway that may ameliorate disease severity in ALS. And what was found was that, in fact, using a drug screening pipeline, they were able to describe that, in fact, beta-lactam antibiotics was able to upregulate the transcription of the glutamate receptor in astrocytes, and that this may, in fact, ameliorate disease severity as demonstrated in the G93A mouse model of ALS, SOD1 mouse model of ALS. Because of this important preclinical discovery, this led to a large phase 3 clinical trial of safe triaxone for treatment of ALS in the early 2010s to 2012 by the safe triaxone study investigators. Unfortunately, this large study also failed to achieve its endpoint in demonstrating efficacy for treatment ALS. However, in spite of the fact that it did not meet its endpoint, we still had an important lesson to be learned from this particular trial. And that is that this was the first adaptive study, including phases 1 to 3 in ALS. The first phase of the study included pharmacokinetics, followed by safety and efficacy, all bundled into one single clinical trial. And this really set the stage of improving trial efficacy, promoting statistical power, and minimizing study risk duration, and decreasing sample size required for ALS clinical trial. And I would say that its impact continues to be seen today in the Healy clinical trial, where novel trial design has been demonstrated to be highly efficient and limiting patients' exposure to the placebo arm of these clinical studies. So the ceftriaxone study, in spite of the fact that it did not achieve this endpoint, was not the end of the story for glutamate toxicity and its role in ALS and the potential for druggable targets in this pathway. More recently, a publication in Cell Press showed that a new target was discovered in the extrasynaptic NMDA receptor that may be druggable. So why is it that it took so long for us to figure out a potential target on the NMDA receptor for the treatment of ALS? Well, the reason for this is that normally when there is a normal function of EAT2 in the human being, the glutamate is released by the presynaptic neuron into the synaptic cleft, and it binds to the synaptic NMDA receptors. However, in the disease conditions such as ALS, when there is decreased EAT2 receptor in the astrocytes, the extracellular glutamate, in fact, interacts with the extrasynaptic NMDA receptor. And for many years, there was no known druggable target on the receptor to disrupt this pathological pathway until 2024, when at the protein moiety on the intracellular portion of the NMDA receptor was discovered, and a druggable target, a compound called FP802 that specifically targets this component of the transmembrane protein was found to disrupt the extracellular NMDA receptor TRPM4 complex, therefore decreasing cell deaths, decreasing inflammatory markers, and more importantly, it demonstrated efficacy in the G93A SOD1 mouse model, as demonstrated in these figures on the right. When treated with this particular compound, the G93A mouse had higher neurological score, maintaining their body weight, and when treated at time of symptom onset, had longer survival when compared to the vehicle or the placebo, suggesting that this may be a useful compound for treatment for sporadic forms of ALS. So far, we've learned quite a few lessons from both successful and unsuccessful ALS clinical trials. due to the numerous ineffective compounds that has been tried in ALS. All the data were then gathered into one resource called the Pooled Resource Open Access ALS Control Database, or the PROACT database. And the premise for creating this database was the idea that ALS trials failed despite promising therapy due to disease heterogeneity, small sample sizes, and lack of predictive tools. So the question came that, is it possible to gather all the data that has been obtained from all these failed trials to figure out whether we can use this data to help us untangle the disease heterogeneity and find a more effective predictive tool that will allow us to have more successful trials. So the PROACT database is composed of all the data from phase 2 and phase 3 ALS clinical trials that took place between 1990 and 2010, and which included 17 trials. And a common data structure was created and claimed, and longitudinal data from over 8,600 people with ALS were included with 11 distinct data categories and 8 million data points. And this database was launched in December of 2012. And to demonstrate the impact of the PROACT, within 2 years of the launch of this database, over 41 pharmaceutical companies, 100 academics, and 400 researchers in 41 countries access this database to develop studies to evaluate biomarkers of natural history, clinical trial stimulation, cost reduction, and stratification in ALS. So this PROACT database, in fact, had a large impact, even though most of the data were obtained from clinical trials that did not meet its outcome measure. So what were some of the important takeaway lessons from the PROACT database? First and foremost, that collaboration and building a robust database is critical for rare disorders in order for us to have sufficient data to develop adequate models for disease prediction be used in clinical trials. Another important takeaway point from PROACT was that, in fact, it demonstrated the average decline in ALS functional rating scale is approximately 1 point per month, which is consistent with what has been shown in previous clinical trial. However, with a larger number of ALS patients data included in the particular database, this was certainly a much more convincing data that came from this particular database. Additionally, we learned that the average vital capacity decline was approximately 2.24% per month. And with these two pieces of information, this may allow the concept that perhaps we can use historic controls as a way to evaluate clinical trials rather than having a large placebo-controlled study. Additionally, other data that was obtained from the PROACT database demonstrated that overall onset patients, in fact, do have shorter survival, and older age of onset was also associated with shorter survival. While this type of information has been known previously, the PROACT database really demonstrated this in a much larger cohort of ALS patients. Additionally, the PROACT database provided some putative biomarkers that may predict this disease progression. As an example, uric acid was found to be associated with slower ALS functional rating scale decrease and vital capacity decline, as well as longer survival. And creatinine was also associated with slower progression and 27% improved survival per milligram per deciliter. While these, again, have been suggested in previous study, being able to examine a larger database that includes thousands of data points and patients really provide a level of robustness to this data that was previously unachievable. Most importantly, one of the important data points that came out of the PROACT database was that there was a strong correlation between a person's body weight and their risk of death in ALS. As shown in this graph, blue is patients who are more obese, red is individuals who are underweight or normal weight. Red is a patient who are overweight, and green is individuals who are underweight or normal weight. as you can see here demonstrated in the survival curve, individuals who were obese had the slowest disease progression, followed by individuals who were overweight, and the patients who were underweight or normal weight had the fastest progression. Not only did this provide a basis for stratifying patients based on their baseline weight for future clinical trial, this also had an enormous impact on the way that we treat patients with ALS today. Based on these findings, it was this really further encouraged ALS specialists to intervene to provide nutritional intervention early in disease onset to minimize weight loss, and also to apply interventions such as recommending peg tube placement to maintain weight as the patients continue to progress in their disease. So we have learned that a large database can help us provide improved understanding of the clinical progression of patients that will allow us to improve patient care as well as stratification in ALS clinical trial. Now I'd like to pivot a little bit and to talk about what we learned from the ALS clinical trials. And this was a story that was probably very familiar to many of you when this study was published in 2007. This was huge news in the world of ALS because this was in this study, it showed that lithium, which has been known to promote autophagy and protect against mitochondrial dysfunction, may be effective in slowing progression in ALS. In this manuscript, it showed in the SOD1 G93 mouse model that treatment with lithium improved survival by approximately 36%, and it slowed disease progression, and at pathology, it decreased the pathological abnormalities that are typically seen in SOD1 mutation, including SOD1 aggregation and improved autophagy. When a small open-label clinical trial was conducted of 44 patients with ALS, this group was able to demonstrate that there were no deaths in the lithium group compared to 30% mortality in the control. Additionally, there was improved stabilization or slower progression in the clinical outcome measures in these ALS patients, suggesting that lithium may be effective treatment in ALS. Because of the controversy as well as the excitement that surrounded this particular publication, 5 additional studies were subsequently undertaken to examine whether or not lithium had any clinical effect in ALS, ultimately leading up to the Lighthouse study, which is a phase 3 multi-center randomized double-blind placebo-controlled study. Unfortunately, these 5 studies, despite being conducted by some of the best ALS clinical trialists globally, all of them failed to find an effect for lithium carbonate in ALS. This really led to this commentary by Adriano Chio and his colleague Gabriel Mora in publishing this commentary that the final chapter of ALS lithium saga, that this was the death knell for lithium in the treatment of ALS. However, this turned out to not be the case. Because of the large number of studies that was focused on lithium in ALS, a meta-analysis of pharmacogenetic interactions was conducted by the Dutch group and in collaboration with the European study groups, ALS study groups, to assess the genetic subgroups, whether or not they respond to lithium carbonate in the ALS trials. They used a meta-analysis using individual participant data from the randomized control studies to examine whether UNC13 and C9orf72, which are known to have confer a worse prognosis in ALS, may be impacted by treatment with lithium. And what was shown in this particular study was that in individuals who are non-carriers of the UNC13 variant in C9orf72, there was no difference in the survival, whether or not they were treated with lithium. In UNC13A gene variant carriers, however, it was demonstrated that individuals who had lithium, who were treated with lithium, had slower progression as demonstrated in green here compared to individuals who were not treated with lithium, suggesting that in ALS patients who are also carriers of the UNC13 gene variant, in fact, lithium may have a slow, may have confer a slower disease progression on in this group. So this has led to a clinical trial which is currently undergoing in Europe and also Australia, where lithium carbonate is being examined specifically in patients with homozygous C allele at the SNP in UNC13A. And this is a protocol for a confirmatory randomized group sequential event-driven double-blind placebo-controlled study. So the lessons to be learned from the lithium ALS clinical trial is that sometimes early phase studies may suggest a beneficial effect in ALS. However, large phase 3 clinical trials may not necessarily be able to identify a subgroup of patients who may harbor a particular genetic variant that may benefit from that particular treatment. So I provided about 5 examples of lessons that we have learned both from successful and unsuccessful ALS clinical trials, both for outcome measures and underlying biology of ALS. But the reality for our patients today is that there still is a lack of effective therapy to slow disease progression. So what is the future of ALS clinical trials? I think the foundation of a successful future trial really lies in better understanding of the disease progression and the clinical measures that are important to identify that may allow us to translate into biological models as well as clinical trials to stratify the patients in order to predict a more successful, lead a more successful compound into treatment. And this is already under development as evidenced by the King staging and ALS model staging, where we are able to now more effectively predict the stage of the patient as they progress through the course of ALS. Additionally, we need to better identify ALS risks and prognosis, including the genetic architecture as well as the exposome, and develop a large database to characterize the clinical and demographic features of slow and rapidly progressive ALS, which will allow for more effective stratification. And this is an example of what we can learn from the clinical and demographic data that has been collected over many years from ALS patients. And this is a publication from our colleagues, Brian Traynor and his group here, where they examined whether or not they could use a mechanism-free repurposing drug pipeline for drug discovery in C9orf72 ALS. So the premise of this particular pipeline is that the first step is to identify risks in sporadic ALS and to determine whether those risks also exist in C9orf72 carriers. What specifically, Brian and his group were able to identify genetic risks that affected the age of onset in patients with sporadic ALS as well as C9orf ALS carriers. Once those risks were identified, they analyzed the top hits among the genes to determine whether or not there were druggable targets that can disrupt the multiple pathways that involve those genes that affect the age of onset for these particular patients. And they were able to use in silico validation to determine which drug had the highest likelihood of targeting neurons in the brain and cerebellum, and also to widely disrupt these pathways that can affect the risk of the age of onset in C9 patients. Finally, once they identified the drug, the effect on motor neurons in ALS was further validated using iPS cells, both from both from healthy as well as ALS, and they were able to demonstrate that acamprosate was able to disrupt some of these pathways and also decrease cell death in these iPS cells, motor neurons. So this is really has led to a new protocol that's going to be developed here at the NIH, where we will examine in the phase 1 open label study of acamprosate in patients who are carrying C9orf72 mutation in ALS. So I'd just like to conclude with our last couple of slides, which is that ALS is a very challenging field, and that in spite of the multiple failed clinical trials, we should not give up on patients, and also that these failed trials have also taught us many lessons about both the biology and the outcome measures that are important in ALS. So from this quote by Winston Churchill, "Success is not final, failure is not fatal, and it's the courage to continue that counts." And I think this is an important lesson both for us as clinician researchers, as well as for all the patients and their caregivers who are currently living with this life-altering and devastating disorder. So just in summary, negative trials can inform future research, and I think that this is a important concept that we should all keep in mind, and that when developing a clinical trial, it is important for us to think about what biofluids and data that we should collect, so that even if the compound that we are examining turns out not to be effective in slowing disease progression, this may inform future basic science research as well as clinical studies. I think that we have, based on these ALS clinical trials, have learned that stratification is important and should integrate clinical, demographics, genetic, and exposome and prognostic data. And finally, I think that it is important that as we think about the design of the trial, that we innovate because it is critical for new paradigms to be developed in ALS clinical trial in order to accelerate discovery. And I will end there and take any questions. Thank you.
Thank you so much, Dr. Kwan. Any questions? Okay. They're asking, I was wondering how your envision artificial intelligence play a role in accelerating drug discovery and deepening our understanding of disease progression.
I think that's a really terrific question and very timely. I think that artificial intelligence will continue to play a greater role in the ALS clinical trial as well as in drug discovery, in that we now have developed these very large databases systematically. And this is a prime time for us to apply these new technologies to analyze what are the subgroups that may respond to treatment using the paradigm that was set by us by the UNC13A gene variant as an example, to determine whether our subgroups who harbor some particular types of gene variant that may be responsive to treatment. Additionally, there may be patient characteristics that are yet to be unidentified that make them more likely to respond to a particular treatment because the patients themselves may share the same disease mechanism.
Thank you. There are so many questions. I'm not sure if you have enough time. Okay, they asked that how much attention is directed at gene-specific populations.
So I see this. I think there is a large effort to examine gene-specific therapies because this is what we consider low-hanging fruit. So when we have this is really the paradigm of the right mechanism, the right drug, right patient population, and right clinical trial. And this is really the ideal situation if there's a druggable target for a particular gene mutation. I think that there's certainly an effort, and I think some of this effort is being led by Neil Schneider up in Columbia to develop a platform to quickly move gene therapy through the pipeline. But I think that while this is quite important, I don't think we should leave our sporadic patients behind, those individuals who do not have a gene mutation. So I think that the development can be twofold. We can look at gene risks from the traditional concept where a person has a Mendelian gene mutation that leads to what we typically see in patients. But we also need to look at polygenetic risk factors that maybe there are risk genes, one or more, that has been yet to be identified, and that we need to think about this from that perspective as well. So are those multiple gene risk factors druggable, and can we target them in clinical trials?
So much. There's a question about can you discuss the large new ALS trials? I mean, we can.
Yeah. Well, I think that there
is a lot of trials.
Right. So I think that I think that that's a fair question, in that I think that what is exciting, that there continue to be a robust pipeline, right? I think that's really important to recognize that ALS is a very difficult disease to treat, that has many failures, and it's very discouraging. But I think that as a field, ALS researchers have really engaged industry to try to find potential compounds that would be beneficial. And I think that the HEALY clinical trial platform is a really fantastic platform to quickly evaluate new agents for treatment and minimizing participant risk to placebo. So I think that, yes, there are many exciting new drugs that's on the horizon, and I think that we have to figure out a way to get them through the pipeline in a smarter way and more efficient way. And then certainly the platform study is one such method.
Yeah, and Dr. Novak asked about a case that he's following. It's a case that the course stopped, and the patient has a typical presentation of ALS with hyperreflexia and fasciculation and weakness, but now it's not getting worse. Any comment about cases like that?
Yeah, so I think that every so often we come across individuals who have all the typical symptoms of ALS and examination finding, and their progression is atypical. And I think this continues to be an area that is challenging for ALS specialists, in that we do not have a diagnostic marker sensitive and specific for ALS. So, while the patients may have all the clinical manifestations of motor neuron disease, I think we always have to raise that question: is this ALS, when they do not progress as expected? And I think that even though we think that as neurologists, we are very good at making these different diagnoses, but they are atypical individuals, in which case that we do need a biomarker that is sensitive and specific for ALS. And I think that's an area that really requires more effort.
Thank you. And I have a question, except, the commercial light chain neurofilament and CK aldolase that we're checking for ALS patients, is there anything else commercial for physicians?
Not at this point. And I think that we're all hoping for a TTP43 biomarker to come along, especially one that's available through blood, that can help us determine more specifically the underlying pathology. Ellie, you're muted.
Thank you. There's a question about, a general neurologist, what exactly they should know and when to involve the patient into multidisciplinary team.
Yeah, I would say that many of our general neurology colleagues are really superb clinicians, and they already suspect the diagnosis of ALS. And what I often recommend is that they refer the patients to a neuromuscular specialist as early as possible. when they themselves suspect ALS. Um, you know, when I take a very straight typical approach. We always expect the worst but hope for the best, right? When we see patients. So if my encouragement for our general neurology colleague is that refer early, and especially when there even is a slight suspicion, because we are trying to capture those patients in clinical trial. And it may be that we are able to start them on, enroll them in study earlier, we may find a better signal.
Thank you. Let me see if there's anything. Okay, there's a question about hyperbaric oxygen therapy. Any comment on that?
Yeah, I'm not aware of the data, so I think that I don't have any comments because that's not data that I'm aware of.
I have a question. Do you have any update about stem cell, Justin?
Yeah, so I think that the stem cell therapy, it is unclear what is its role in ALS. I think that we have been disappointed by the stem cell study, most recent with the mesenchymal stem cell study in ALS. Um, I think that there may be a role, and I think that once again, we need to identify the right cells. Where how are we going to apply those cells? What are they going to do in ALS? Who are the patients who are likely to respond? And also, when we conduct those trials, what are the outcome measures that would be most relevant that demonstrates target engagement, and also that's able to show that in fact it is able to prolong motor neuron survival. And I think that once again we go back to those fundamentals.
And probably the last question, because we're running out of time. How important is the diagnosis of preclinical or early stage ALS for enrollment in clinical trials? And what is the current state of the art?
Yeah, I think it's going to become more and more important, particularly in gene mutation carriers, because those are the individuals who we can identify who are potential at risk. I think it's much more challenging for sporadic ALS in that we don't know who are the people who are truly at risk unless we are able to come up with, for example, a polygenetic risk score for the general population and be able to effectively deploy it. I think that is a sort of a pie in the sky. Who are the people at risk for neurodegeneration? What are the risk factors? And what kind of neurodegenerative disorder will they develop? But until we can achieve that, I think right now, I think the best population that we can examine to answer those questions are individuals who are gene mutation carriers. But I think that before we can even tackle that particular problem, we need to know, when does phenoconversion really happen? Because we want to determine the right time for intervention. I think that this is again a moving goalpost, right? So when is that right time? We don't really know. So I think that this is one of those situations where global collaboration has to really take place, because these rare diseases, we have so few people living with them. We need more data, and that data can only come from collaboration.
Thank you so very much, Dr. Kwan. I really appreciate it.
Thank you, Dr. Baya, for the very kind invitation, and thank you for all of you for your excellent questions and for staying with us today.
Appreciate it.
Thank you. Bye-bye.